Yeah, hello. It's great to be back again to Egypt and to this meeting and to see so many friends. I've learned about this presentation only a little more than a week ago, so if it's not going to be perfect, excuse me for that. And I'm going to take you on a voyage, on a fast, very fast voyage, so fasten your seatbelts, please, through the question PCI or cabbage, and the question, what does gold standard mean? And at the end, I'm going to answer this question, and it's looking a little different. So, as you all know, and we're here in Egypt, coronary artery disease is as old as civilization. And this is a CT finding from a mummy showing calcification, severe calcification, but not at the quality we were just presented a few seconds ago. And the Ibis Papyrus, 3,600 years ago, said if Thor examines the man for illness in his cardia, and he has pains in his arms, in his breast, and in the side of his cardia, and it said of him, it is illness, then thou shalt say thereof, it is due to something entering the mouth, it is death that threatens him. So almost 4,000 years ago, the same problem we are facing today. You know, three vessel disease, in my opinion, always is a revascularization matter, which is always a heart team approach. And here you see a 14-year-old picture with my dear friend Sir Magdi, which all of you know. Definition of gold standard, what is it? It's not gold standard anymore if we're inserting a balloon into patients, like in this cartoon. And it's also not gold standard to have a patient with 67 stents. With this finding, you don't need CT anymore because you see it in an X-ray. The definition of gold standard on Wikipedia refers to popular clinical endpoints by which scientific evidence is ever evaluated, for example, in resuscitation research. But what are we talking here about? Gold standard, in our opinion, should be to treat the patient right and as good as possible, and to cut out the oculostenotic reflex. To do the right thing right. To avoid too many catheterizations, no DRG or reimbursement splitting to make more money in your hospital, to find proof for ischemia, and that's not only the bottom line, this is the headline, perform evidence-based medicine. And you know, there's a saying about the dollar, in God we trust, and the saying in the scientific world is, all others bring data. So I'm going to show you some data. This is the guidelines on chronic coronary syndromes from 2019 from the EC. And they were focusing on invasive angiography as the way to rule in, as we would say today, coronary artery disease. And you're all familiar with these pictures. That's the timeline for chronic coronary syndromes, subclinical phase, recent diagnosis, and then long-standing diagnosis. With acute coronary syndromes, revascularization, 12-month post-ACS. And there are some screws to turn to have a better outcome. We know that cardiovascular risk factors increase, bad lifestyle matters decrease, medical therapy, if not taken in, or myocardial ischemia getting worse, are shortening the periods from this event to another event. And if you lower the risk factors, if you change your lifestyle, if you stay to secondary prevention, and if you revascularize the patient, the outcome is much better and the patient has chances to live longer. These studies are all familiar to you, and we are always looking to have a complete revascularization. At the right side, you see the complete study showing that complete revasc was superior regarding to reinfarction, superior to repeat revasc, and superior to primary outcome. The Compare Acute trial, same thing, complete revasc, much better outcome, much better survival, MACE-free survival, than if you treat infarct-related artery only. STEMI, complete trial again, culprit lesion only, worse outcome, complete revasculation, much better outcome. Bangalore presented a great study about 8 years ago, showing that treatment of the patient is much better. There's only one exclusion, and this was the study presented by my dear friend Holger Thiele from Leipzig, the culprit shot trial, showing that you go on treating patients in shock. If you do everything, if you revasc everything, the outcome is worse. This is a typical patient, 73-year-old male, stable angina, with a slight aortic stenosis, diabetes, and a syntax score of 11. And you see the LAD compromised, and something in between the middle circ, which is an intermediate stenosis. So the question is, are we going to treat this patient in all vessels or not? And there's also the picture of the right coronary artery you just saw just a second ago. Here it is, also a little compromised, diffuse diabetic type coronary artery disease. And there are evidence-based reflections. We're talking about prognosis, we're talking about symptoms. Prognosis is lifestyle modification, control of risk factors, lipid treatment, antiplatelet therapy, and then the question, revascularization, yes or no. And symptoms, to treat symptoms, beta blockers, nitrates, calcium antagonists, and again, revasc. Now the question in 2025 is which decision to make. And we're turning the wheel and it says, well, of course, PCI. Or this way. Now it doesn't turn. Let's try. Yes, it's turning. So is the first slide the right one? Or is this the right one? Again, telling you PCI, but. So these are old data comparing PCI to CABG from 2014. And you see on the left-hand side, the blue columns, like these are the PCIs. The gray columns are the CABGs. Germany is leading, and other countries are trailing far behind. More recent data, PCI 2022, the latest available data per million inhabitants. And you see between the red arrow, Germany, the high column, 4,000 per million PCI per million inhabitants, and Egypt with roughly 700, 800 PCI per million inhabitants. So that's the difference. So in this case I showed you, we made a pragmatic decision. We stented or treated LAD first, and after FFR, that's the clue, also the circumflex was treated. Now looking at the studies, can PCI reduce mortality? And here you see a lot of well-known studies from MASS2 to Revived, and you see there's not a single study showing that we have a real mortality reduction by PCI. So how are the surgeons doing? Not much better, actually. But the comparison is these trials are up to 40 years old, no routine aspirin, no statins, no ACE inhibitors, and the recruitment ended in 2007, and there was no heart failure therapy with the 4 pillars we're installing today. Stitch data, mortality 5 versus 10 years. You see, medical therapy is doing less good than CABG. And Rivas guideline HAACC SKY in 2021 said you have to select patients with multivessel disease, first of all for CABG, and then decide about PCI. Navarrese published a study in 2021 following the Cochrane guidelines, and all 25 RCTs were included. 19,000 patients, after all, CCS patients, and mean age lower than 66, average follow-up 5.7 years. And you see random effects models that revascularization plus medical therapy was doing a little better than medical therapy alone. Same thing with spontaneous myocardial infarction, a little favor for revasc. These are the recommendations from 2024 from Human Heart Journal, dividing patients into those with low LVEF below 35 and above 35%. And you see in green that CABG and PCI are equally distributed in the patients with higher LVEF, but in the patients with compromised left ventricles and high surgical risk, PCI is with a yellow recommendation and not very high, again, CABG. So the question is, what are we doing? Are we treating symptoms? If we're talking about symptoms, and we're going to hear about the ischemia trial, so I'm not covering this at the moment. if you go to the direct comparison between CABG and PCI, Syntax, BEST, Freedom, and FAME3, you see that except maybe the BEST study, it turns a little more in the direction of CABG. I'm going to skip this slide for the sake of the time. FAME3 study, very important, 5 years results, death, myocardial infarction, and stroke, no difference between PCI and CABG. Low syntax score, there is a difference. High syntax score, at the end of the day, still there's a little difference. And in the immediate syntax score, there's a high difference of cumulative event rate in PCI patients. So why are we doing PCIs? Now you have the comparison between FAME3 and syntax. Death, strokes, and myocardial infarction at 5 years. The PCI cohort is doing worse than the CABG cohort. And I'm an interventional cardiologist. So how can we improve PCI results? By imaging. You just saw the beautiful pictures about imaging. And why and what for imaging? Modification of lesson necessary? Yes. Risk of stent underexpansion? Yes. Risk of complications? Yes. It's important to have good images. And intravascular imaging in PCI is IVUS and OCT. And in the bottom part of the picture, you see how beautiful this flower develops the more you go into being invasive in imaging. There are 3 very good studies, OCT or angiography, intravascular image-guided angiography with complex PCI by Lee, and OCT versus angiography-guided PCI. And you see the results are favoring the image-guided PCI. So I would say, also going to the network data, Stone presented or published in Lancet about 1.5 years ago, comparison between angio, OCT, and IVUS, you see with all the studies done that there is a plus for people undergoing invasive imaging. So the conclusion, we are all doing PCI without IVI since ages, people might say, and we should answer yes, but you're all wrong. For a guided complete PCI with IVI versus CABG, these are the data from Lee, published 1 year ago. And you see the blue lines at the bottom of all these pictures means that in total population, in the matched population between IVI and CABG, and matched population between angiography and CABG, you have different findings. And the most interesting finding is that the curves in the middle portion in picture B are almost superimposing completely. By the way, nobody ever questions of all the bypasses on vessels with intermediate stenosis, scars, no proof for ischemia, really made sense. And coming back to the cardiac surgeons, ocular stenotic reflex. It's interesting that we have this finding because I would like to see if you have a complete CABG study focusing on this question. 24 ESC guidelines on chronic coronary syndromes, and now they're focusing on intravascular imaging. And I think this is the key to success for the future. And the next RCT, guided 3 vessel disease, is going to be 3 vessel disease with and without left main. PCI with functional full revasc plus IVI compared to CABG. 1-year death, MI, stroke, co-primary endpoint, and 5-year death, MI, stroke, primary endpoint. And I'll be interested to see what's happening then. So the question is revasculation 2028 and following. What do you expect? Yes, still PCI with the findings of these studies. And the answer to the first question, is there a conundrum or dilemma in what we're doing? No, functional completeness is the gold standard for revascularization in chronic coronary disease and chronic syndromes, but this is the target we are facing in the future. Obese people, I know you have a lot of obese people, also in Egypt, all over the world. United States still is top ranking with the president eating hamburgers and drinking Coke. But these are really the target people we have to target. And the question is if you can get, coming back to CT, these people into your scanner. So thank you very much. Shukran khair.